Thanks for having me here this morning. You know, I've been to so many conferences. You see what I wear to a conference in April: a sweater, a long sleeve shirt. I'm always freezing in these places. Yeah, just a quick question. Somebody asked about hemochromatosis. I also, as a gastroenterologist and hepatologist, have never heard of any correlation between those two disorders. Don't get me wrong, hemochromatosis is one of the more common genetic abnormalities, particularly in Caucasians. However, I've not heard of any connection or association with scleroderma. As a matter of fact, liver diseases are pretty rare in scleroderma. And as a matter of fact, the only one I know of is something called primary sclerosing cholangitis, which occurs in about 2%, and that's pretty rare. So most of my talk today is going to focus on sort of the luminal or the tubular GI tract, not the solid GI tract. So we don't see much disease with the liver or the pancreas, although there have been a few case reports here and there. So I trained at Chicago, and before I got to U of C, I was at a Michael Reese, may it rest in peace. It's now a vacant lot on the south side. I can't show my kids where I trained because it's just it's kind of a sad story, but while I was there, I met Michael Ellman, who we heard about a little bit earlier, and he was the reason I came that close to going into rheumatology. The only reason I didn't go into rheumatology is they had better toys in gastroenterology, and I like gadgets, so that's why I'm here. But another person I met, who some of you may know here in Chicago, is Chuck Winans. I don't know if any of you ever bumped into him. He was the esophagologist over there when I was training. So he was the one that taught me about GI motility, and so I saw a lot of scleroderma patients with him. And of course, I saw a lot of scleroderma patients with Mike Ellman, so it became an interest of mine throughout my third-year GI career at Rush. So I have quite a number of scleroderma patients and help rheumatologists with them. How many of you have heartburn in the audience? So I raised my hand too because I also have it. The nice thing about that is you can be empathetic. So even if you don't have scleroderma, you know how miserable reflux can be. I had reflux so bad in the pre-Prilosec proton pump inhibitor era that I developed a stricture as a fellow, so I couldn't swallow one day, and that wasn't fun. Back then, Chuck Winans, who was training me, became my gastroenterologist, and he did an upper endoscopy on me, so I got to be on the other side of that particular procedure, and he found a stricture. So he took a thing that I think is only in the museum now called an Eder-Pusteau dilator. Eder-Pusteau dilator was a metal rod in which he affixed a metal olive, and he shoved it in there, and he broke through the stricture. And he kept doing bigger olives until he got it all the way opened up. We've gotten rid of that thing. It's in the museums now, but I empathize if you've had strictures, and I empathize if you have reflux disease because I've certainly experienced it myself. So when my scleroderma patients and I talk about reflux, we have a kindred spirit there. So I won't spend too much time on the disease, so you've already heard about that, but quite prevalent. Certainly I see a lot more women than men. Ages 35 to 65 typically for me in my clinic, cause is really unknown. I'll go into just a real quick sum up because we already went through this, but there appears to be abnormalities at a vascular level that then lead to sort of a loss of oxygen for tissues. This leads to abnormal repair, perhaps genetically driven. This leads to the scarring. And the scarring affects the skin, but certainly that scarring affects the GI tract, damaging both the motility or the motor aspect of your bowel as well as the neurologic innervation, causing significant troubles with the GI tract. 95% of people with scleroderma will have GI abnormalities, yet only 50% have symptoms, which is why every patient, in my estimation, again, biased here, should be co-managed by a rheumatologist and a gastroenterologist. I think every patient with scleroderma should have a gastroenterologist on board because if you find things early, then again, just like with scleroderma in general, the earlier you get to it, the better the outcomes. So since half of the scleroderma patients will not have GI symptoms at presentation, it's a good idea to see us, get a head start with things. And I really push for getting at least an upper endoscopy done on almost everybody I see with scleroderma out the gate to make sure there's not a sort of a disguised reflux injury. Because untreated reflux injury leads to untreated lung injury. And lung injury is one of the big sort of devastating aspects of this disease. But if you fix the reflux, you protect the lungs. So again, it's important to diagnose sort of asymptomatic reflux disease early on. We have some of the best medications I have for the GI tract in scleroderma are in the reflux area. It's just a shame when people don't get that diagnosed, go on to stricturing, go on to Barrett's, go on to lung injury, when we could have been a little ahead on that curve. So here's our GI tract anatomy. We're basically a big donut, right? Hole here, hole there, big tube in between. So it's just one long, very specialized donut, I might add, but nonetheless, kind of looks like a subway system. As a matter of fact, I found one schematic of the GI tract that looks like a subway system. But basically, as we sort of mentioned, from mouth to anus, you can have trouble with the GI tract and scleroderma. So again, we have to address all of these areas pretty routinely. As I mentioned, though, the one good news is that we don't see much in the way of gallbladder disease, pancreatic disease, and liver disease. So the solid organs tend to be sort of left out of the picture. It's mostly a disease of the lumen of the gut, it's the tube, if you will. Now, we're a little more complicated than my picture of the London subway here. It's kind of an amazing sort of tubular system. It's got two different muscle layers, one that's longitudinal, one that's sort of like the subway system, a sort of a circular layer. They're involved in the prokinesis, or the motility of the gut. It's got its own brain, which is kind of cool. So you can cut the nerves to the gut from your big brain, the one up here, and it's still got enough of its own brain power to figure out how to secrete, how to move, how to react, how to cause pain. So it's pretty self-sufficient, although the big brain, the God up here, sort of tells the shepherd down below how to sort of behave a little bit. So there is important information coming from your brain down to your gut regarding motility and secretion and the sensation of pain and discomfort. So a little bit on function of the GI tract. So again, chewing, basically, pretty simple process, although swallowing is amazing. When I was in medical school, I was fascinated by the swallowing reflex. When we swallow, that is one amazing bit of neurology and motor anatomy working together to create a swallow. And there are lots of things that can kind of mess that up. Unfortunately, with scleroderma, due to the tightening of the skin, chewing can be problematic. And due to bad reflux disease, the teeth can get destroyed. Another reason for going to see your gastroenterologist, because I have a lot of patients who present with tooth enamel loss and chipping and broken teeth. That's because they've had badly or poorly treated reflux disease, and the acid's getting up and they're etching the enamel and destroying the teeth. So in addition to being unable to chew, you may destroy your teeth with this reflux process. Reflux, when it gets up into here, acid, let me tell you, the esophagus doesn't like acid particularly well. It's okay at handling it, but it's not great. This area, your oral pharynx, has no clue what to do with acid. It is easily damaged. And all sorts of things, from dysphonia, meaning change in your voice, chronic sinusitis, chronic infection in the sinuses, chronic ear infections, tooth enamel loss, burning tongue, oral pharyngeal injury, laryngeal ulcers, chronic cough, throat clearing, excess secretions, nocturnal acid breakthrough. All of those are sort of related to severe reflux into the oral pharynx. And with scleroderma, because your esophagus doesn't have that motor power, the pump function, to push acid back down into the stomach. And it's lost the strength of that valve at the bottom to protect you from that reflux of material coming up. Oral pharyngeal complaints are pretty common. Yet, we have great medications for that. So again, it sounds kind of doom and gloom, but if you're on good proton pump inhibitor therapy, you will deal well with that process. Downstream, the stomach doesn't empty well. In some scleroderma patients, about a third get gastroparesis. Does two things. It can interfere with your absorption of food. Number two, it can cause more reflux. You don't empty the stomach well, you've got it's kind of a double whammy. You don't empty the stomach well, you've got a poorly clearing and structured esophagus, and now you can get some pretty wicked reflux, particularly at nighttime. So I'm sure some of you have reflux disease. When I get a bad episode of reflux disease, it's usually because I forgot to take my medications, and nighttime is terrible for me if I get a reflux event. And you got gravity working against you, right? So you lie down, and now the connection between the stomach and the esophagus is pretty even, and gravity isn't helping at all. So it's problematic at night. Obviously, then there's the small bowel. Small bowel can develop mostly stasis, slow transit. When things don't move well through your small bowel, it goes from a pretty sterile place to a place that may be infected with, although not dangerous bacteria, ones that don't belong there. So even if your normal gut microbiota, and as you might know from reading the newspapers later, there's a lot of discussion about what the microbiota in your colon does or doesn't do for you. But in general, it's pretty friendly, unless it gets into bad places. And one of the bad places it can get into is into your small bowel, where it interferes with your absorption of food, and that can be a problem. So we'll talk about bacterial overgrowth here down the road. Then getting down to the colon, constipation is almost as common as reflux is in my patient with scleroderma. And so we're always fighting with the colon, trying to get it to move so the stool doesn't get impacted and become a problem. Finally, there's the anal rectum. So there can be issues with rectal prolapse. There can be issues with anal incontinence. So we end up having to do a fair amount of work down in this area as well. Luckily, I don't see as much of this as I see just standard constipation in patients with scleroderma. So the upper GI tract's involved or lower GI tract's involved in 90, it might even be as high as 95% of patients. We see it both in the limited and the cutaneous form. Key thing, there are people who basically have no skin manifestations, who have very severe GI manifestations. fair number of people we diagnose with scleroderma come in with refractory reflux disease. The primary care docs tried everything, they're still refluxing, they're getting trouble at night. We do a motility study, or we do an endoscopy, find severe reflux. Do the motility study, and we find what we call a scleroderma esophagus. So you see that loss of motility, the lax or the lower esophageal sphincter pressures. And we end up making the diagnosis not via skin, but or other organ involvement by the GI tract. That's not uncommon, particularly in patients with severe refractory reflux disease. As I mentioned, it can affect any organ in the GI tract, although solid organs not particularly problematic and can be slowly or rapidly progressive. Young or old, so that we have that age range, mid-30s to mid-60s. You can see GI tract involvement anywhere along that spectrum. So how do you grade the disease? Well, in the GI tract we have 4 grades, so there's grade 0, and that's basically just blood vessel injury. We're still seeing good GI motility, still seeing good GI secretion. The patient may not have much in the way of symptoms with grade 0 injury, and it may only be noted on biopsy. Grade 2, we're starting to get into nerve injury. So when you injure the nerves in the GI tract, you will get abnormalities in motility. A little easier to treat when it's just nerve injury because the muscles are still working. So you can give what we call pro-kinetic or pro-motility drugs to try and kickstart the GI tract and get it moving. So we do usually get a little better response to some of our pro-motility drugs when we have a grade 1 injury. You start getting into grade 3 injury, now it's sort of like, the sheepdog's not moving, the muscle, the sheep of sort of the GI tract who respond to everything they're told to do stop working. And so it doesn't matter how much you sort of whip the system up with prokinetic drugs, if the muscles at the base layer aren't working, you're not going to get any kind of particular motility that you'd like, and that becomes a bit of an issue, where stasis and slow motility become tough to treat. And then it really gets difficult when you get down to scarring and fibrosis. Because not only here are the muscles not working, but there's so much scarring that you may get an obstruction. So now you have that double whammy of a poor motility or poor pump function of the GI tract and a structural obstruction. And that's a very difficult situation to be in. So let's go on to some specific organ sites. Talk about normal swallowing of food. So you chew food. A guy had breakfast this morning, so you chewed food, you added a bunch of saliva to it as a lubricant. You went through this amazingly complex technique of actually forming the food bolus, pushing it in the back of your throat, opening up the valve at the top of the esophagus, closing the valves to your lungs so it didn't go into your trachea, pushing it through, and then a series of different kinds of peristalsis or motility in the esophagus to move it down to the bottom. There's something called primary peristalsis. That's where the food bolus, you start at the top and you push it all the way down in a nice sort of from the mouth to stomach sort of orientation. If a little bit's left in the esophagus, you then develop what we call secondary peristalsis, where the motility event starts in the middle of the esophagus and pumps the rest of it out. It's that secondary peristalsis that clears out those reflux events. So let's say everybody refluxes in here. Sometimes you feel it, mostly you don't. But what happens is that when you reflux after eating back a little bit up into the esophagus, that secondary wave kicks in and pushes it back down. That's that pump function of the esophagus. And there's something called tertiary waves of your esophagus. And some of us get those as we get older. Scleroderma patients can have them. These are sort of random, sort of not particularly propulsive movements of the esophagus. When I squeeze a tube of toothpaste, I start at the bottom, I push towards the top, right? When my kids, as little kids, would do this, squeeze it anywhere. And sometimes it came out, sometimes went back into the bottom of the tube. It was not a very efficient way of clearing the toothpaste tube. Same thing with tertiary contractions in your esophagus. They're not very efficient. They're sort of random. And if 2 random ones hit at the same time in the middle of your esophagus, food gets stuck in the middle. You may get a sense of chest tightness or fullness that's uncomfortable. So we do see these kind of random, not particularly helpful waves in patients who have scleroderma. But a lot of times, particularly as we get into the more muscular injury, then we just don't see anything. So the top part of the esophagus is what we call striated muscle. That's the muscle here in your hands and your legs, and that stays pretty much intact. The bottom 2/3 of your esophagus are what we call smooth muscle. That's the muscle through the GI tract that kind of functions on its own. You don't, after you eat, luckily you don't have to think about pushing your GI tract to move things through. That'd be a pain. It does it all automatically. Smooth muscle is automatic. And the problem is that scleroderma damages that smooth muscle. So we see a very characteristic pattern when we do a motility study. Good motility up here, and then it conks out. If we see tertiary waves, or a lot of times just nothing. Just nothing happens. No peristalsis when the patient swallows. And then we look at the valve at the bottom, it just sits there open. It's not tight. It just stays open. When you swallow, it should open, right? Let the food through. But if it stays open, then you've got trouble, particularly with regard to reflux. So, Here's some, let's see if this will run, there we go. So you're looking at one of my endoscopies up top there. So we're looking at the esophagus. Here you can see this patient sort of had quite a pinhole sort of opening. You'll see this patient here had fairly severe erosive disease. So something like this will ultimately go into an image like this. This is easy to treat. You just get you on some proton pump inhibitor class drug and you'll be better. This is a bear. Because this is a really tiny hole, and I've got to start with really tiny balloons. We got rid of those Peter-Pistow dilators, so you'll never see those. I have a cool little balloon that comes out of the end of my scope. And I stick it in there and I blow the balloon up. I make it a little bigger and a little bigger, and I take that one out and I get the next one. And we just keep going up and up and up. But a stricture of that type is going to take me a couple of months to get to the point that I want it to be, because you can't just sort of blow it all up at the same time when perforating the esophagus. So again, you don't want it to be here. We want to treat you here and not have to deal with this here. So as I mentioned, there's a low valve pressure between the stomach and the esophagus. There's that loss of motility. This allows acid to percolate up into the esophagus and sit there and damage it. As I mentioned, the motility problems affect the bottom 2/3 of the esophagus, and as I mentioned, about 50 to 80%, a lot of people get into trouble with severe acid reflux. And it can lead not only to this stenosis, but also can lead to esophagitis, and then something called Barrett's esophagus. Barrett's esophagus, which I'm mentioning in a little bit here, is actually kind of appropriate. I mean, if you're the esophagus and you get tired of getting bathed in acid, why not turn into the lining of the bowel that's pretty tough on acid, and that's the lining of your small intestine. You know, when the acid leaves your stomach, your small intestine sees a whole lot of acid, and it pretty rapidly neutralizes it. But if the small bowel wasn't tough against acid, you'd have a lot of trouble, a lot more ulcers than we have. So the esophagus, in some of you who have the right genetics, will turn into the lining of the small intestine, which in the grand scheme of things ain't a bad idea. However, even if you grow tissue that would theoretically be helpful, but you grow it in the wrong place, there's an increased risk of cancer in that area. So though it's nice to have Barrett's from the standpoint of symptoms, because that's a good acid-resistant lining, it is not good to have that intestinal lining up in there because we see more cancer in that. So when we diagnose you with Barrett's, we have to keep an eye on it. Only every 5 years we go down and take a look and take some biopsies. And these days, if we find Barrett's, and if we find significant precancerous changes, we have a cool little toy called a Barrett's probe. We burn it all off, scrape it down, put you on huge amounts of acid suppression, and surprisingly, you'll heal up nicely back to regular tissue. So the best thing about Barrett's is to know you have it. The worst thing about Barrett's is to have not to turtle on this thing, not get a look down there, and go on through life with Barrett's not being followed up, and then you end up with cancer. The only people I've ever seen in 25, 30 years of practice now with adenocarcinoma of the esophagus were people who didn't get scoped, and they didn't get the Barrett's didn't get discovered and didn't get followed. I have never seen a patient of mine or anybody else in my practice who was having their Barrett's closely followed who went on to cancer, because we always find the problem first and we get it dealt with. So, you know, patients are somewhat disappointed when I find they have Barrett's. I say, nah. Now, you're much happier now than you were before you got here. Before you got here, you didn't know if you had Barrett's. Now you got Barrett's. We just keep an eye on it. And when it causes trouble, we'll get rid of it for you, not surgically. In the old days, before the Barrett's probe came out, to give you a little example, the only treatment I had for Barrett's esophagus was the removal of the esophagus. That is a highly morbid, meaning a very difficult sort of surgery to go through. Before Barrett's came out, I did send one patient in my career for an esophagectomy, and although we're still friendly, he doesn't really like me that much. He's lived a long time, he doesn't have esophageal cancer, but he still kind of hates what we had to do, and I totally get that. It did affect his quality of life. I'm so happy we have ways of dealing with Barrett's. So it's not a scary diagnosis to have. It's a scary diagnosis to not know you have it. That's the scary thing. Whether you have it or you don't, no problem. Just get it done, make sure you don't have it. A little video here just sort of showing you how reflux occurs. So again, here's our swallowing. You'll see how this rolls out here. Just a few things about reflux disease that's poorly treated. In addition to Barrett's, you can get severe erosive esophagitis. This then can go on to cause scarring, which leads to those strictures, or blood loss. You're talking about low ferritin and iron deficiency. Scleroderma patients have reflux that can be so severe with the esophageal injury that they can go on to iron deficiency just from damage in the esophagus. So it's important to get that treated, and treatment's available. High-dose proton pump inhibitors will get rid. This is a pretty full stomach, but you don't have that much acid floating around in there. But that gastric lake is always sort of sitting in there, and it'll tend to come up. And if you're on a proton pump inhibitor, this isn't acid anymore. It's just water, basically. Now, no proton pump inhibitor out there, Prilosec, Nexium, all of those guys, none of them will stop you from refluxing. Because none of them fix the motility problems in refluxers, or scleroderma patients for that matter. What they do is they turn what comes up into something benign. So it goes from acidic, which is damaging, to normal acid levels, no acid. Totally benign, like water, like sodium chloride, it's just nothing. It won't hurt anything. The cool thing about getting rid of acid is when you get rid of acid, you get rid of about 5 other things that damage the esophagus. Proteolytic or protein digesting enzymes, acidic bile salts, something called sulfhydryl compounds. So there are lots of things that come into your esophagus that require acid for activation. Pancreatic enzymes can damage your esophagus. So not only do you get rid of acid, you get rid of these 5 other things that can damage your esophagus. So it's 5 for the price of 1. But, key caveat here, you will still reflux. You still may feel material coming up into the mouth. That is basically impossible to stop with medications. We'll talk about surgical approaches to this if we have patients who are really uncomfortable from reflux, even if it's benign. We'll sometimes try to tighten that valve for you surgically to prevent that. That is a very tricky piece of surgery in a scleroderma patient. Because I've already told you don't have good pump function, right? So if I go in there and put something to tighten that valve, and I can't restore the pump function of the esophagus, you're going to have a devil of a time swallowing. So you need a really skilled surgeon who's really good at sort of doing things very gently and backing off a little bit. So yes, I have sent patients who have bad regurgitation, even with control of acid, to a surgeon. Dr. Chmielewski at Rush is really good. He has lots of cool little different techniques that work nicely with modifications that are good for scleroderma patients. And so far, the 4 scleroderma patients he's operated on for me over the last 12 years now, none of them have had severe trouble swallowing afterwards. But you need a surgeon who does a lot of these. It's typically going to be a chest surgeon, and it's something you do with good consultation and discussion in a scleroderma patient. So, as I mentioned, it's just not heartburn, sore throat, cough, hoarseness, chest burning, burning tongue, excess belching. When you reflux, another thing your body does that's really helpful is it produces more saliva. Because if I can bottle saliva, it's pretty good, no one take it, but it's pretty good stuff for reflux, you know, saliva transplant. Yeah, because it neutralizes acid, it's got healing characteristics for your esophagus, so your body says, okay, if it's burning down there, let's produce more saliva. So you make more saliva, so every time you swallow, even if you sit here right now doing a dry swallow, you take in 5 milliliters of air with every swallow. So the more saliva you make, right, the more you swallow, it's okay. All that air goes in your stomach. And again, if you're a refluxer with a valve that's kind of loose, or you have poor stomach emptying, then guess what? The air's got to come out, right? Excess belching. So most excess belching is a manifestation of reflux disease and what we call aerophagia, or air swallowing, which is very common and actually expected in people with reflux disease. A lot of patients think there's something bad about belching, maybe a little impolite at the table, but it's a physiologic event that you can't control. The air should come out that way. It is, and it doesn't initially indicate disease other than it will reflect reflux. So you can't worry about too much about it. Here's gastroparesis, and this is kind of what we see in the stomach in a gastroparetic patient. We can see these things called bezoars, which are collections of food, typically plant fibers that collect in the stomach and can't empty, and they get so large that they can impact and obstruct the stomach and sometimes need to be surgically removed. But you have right outside the door here, the best treatment, medical treatment for reflux disease is in the machine around the corner, Coke. Straight out, acidic Coke with a little bit of bubbles in it will destroy these things really nicely. We give them 3 cans of Coke a day, and they dissolve like miracles. It's really pretty amazing stuff. They belch a lot, but... So, the only treatment for scleroderma I have in this room right now is right out the door there, it's Coke. So we have a Bezor, drink a lot of Coke at halftime, you'll get rid of it. So, I dissolve all the time with Coke. The ones that don't dissolve are the ones made of hair, but that's more of a psychological issue. The ones made of food dissolve very nicely with Coke. So, yes, you can tear these things up with Coke. I don't know what it does to the rest of you, but it does fix phytobezoars. So they can be associated with a sense of fullness, early satiety, meaning you get full early after meals. Weight loss can occur with these things. The stomach doesn't accommodate, it doesn't stretch open like as nice as it should to accommodate food when it comes in. It just gets stuck there, and it turns into this concretion, which we, again, get rid of with Coke. How do you prevent them from coming back? Well, low-fiber diets, low residue diets. We do what we call a gastroparesis diet. You become more of a grazer than a bolus eater. Most Americans, breakfast, lunch, dinner, breakfast, lunch, dinner. When you have this kind of problem, graze it. Little breakfast, little snack. Little lunch, little snack. Little dinner, little snack. Spread it out. Graze. Don't be a bolus eater. That'll give time for your stomach to empty, and you won't accumulate this stuff over time. So that's a gastroparesis diet. Additionally, low carbohydrate, high fat, high protein actually is pretty good for preventing B-sores. The downside of fat is it kind of slows gastric emptying, so it's kind of a yin and yang on that. But again, if you're getting B-sores, you definitely want to back off a lot of high fiber foods and go more with the fat and the protein. So, small intestine. So most people have a slow intestinal transit rate, about 40 to, well, almost 88% of people, if we measure small bowel transit, it'll be slow. But most people don't have any symptoms, which is nice. What you can get, and what I see most often, as we mentioned earlier, when you don't move the small bowel, bacteria from the colon get back up in there, and they start to mess with your digestion a bit. And we'll talk about how they do that in a minute. You can get pseudo obstructions, which is this dilated bowel, but there's no blockage downstream. It's just not moving well, so it accumulates air and gas. And then something really unusual, though we see it a few times, particularly in scleroderma patients, pneumatosis cystoides intestinalis, which are Latin out here. Basically, it's air in cysts in the wall of the intestine. It's a kind of an interesting sort of physiology where the bacteria in your gut are making a lot of hydrogen. The hydrogen gets into the wall of the bowel. This dilutes out the nitrogen a bit so that the area accumulates nitrogen and can't get out. The treatment's interesting that we give you oxygen. We give you pure oxygen, and it allows the nitrogen to get back out of these cysts and they deflate. Sometimes it's so severe we need to take out part of the small intestine, but I've personally never seen that. Everybody I've seen has responded to either occasional oxygen therapy, antibiotics, or probiotics. So it looks scary. You know, it looks scary. I'll show you a little video of it here in a minute, but it's really pretty benign stuff for most people. So, SIBO. There's a ton of discussion about SIBO at the medical meetings, online. Dr. Google talks a lot about it. Some of it's real, some of it's not so real. Some of people want to just sell you their probiotic online. Other people are sort of going after it in sort of a more caution fashion. But there is no doubt that it is the single biggest problem in the small intestine in scleroderma patients. The bacteria that have been cleared by that motility, what we call peristalsis, start to accumulate in the small bowel, and they get in the way. They start interfering with your absorption of your food, of your starches, of your B12. Not so much your iron, definitely your B12. Iron is absorbed up here, in the top part of your small bowel. B12 down low, the bottom part. So the thing we often see in patients with bacterial overgrowth are two kind of curious findings on blood tests. A low B12 level, it doesn't have to be abnormal, just on the low end. And weirdly enough, a high folic acid level. Folic acid is a B vitamin that bacteria make for you. So if you have a lot of bacteria growing in your small bowel, they're going to be merrily turning your food into lots of folic acid for you. So I have these patients come in who look a little malnourished, but their folic acid's off the charts. That is a really good surrogate marker for bacterial overgrowth without having to do breath tests or culturing the small bowel. You got a sky-high, that combination, that yin and yang, low B12, sky-high folic acid, you're done. That's bacterial overgrowth. Might as well treat it. Don't do a breath test, don't waste your money doing anything else, just go ahead and treat it. Because that scenario you won't see in the scleroderma patient except in bacterial overgrowth. Even in patients with low B12, if there's no other reason for it, in their scleroderma patient, I'm going to assume they have bacterial overgrowth. So keep an eyeball on your B12 levels. B12 level can be low B12 levels can be treated by obviously getting rid of the bacteria, but you know even really high doses like 1,000 to 2,000 milligrams of B12 a day will do the trick. So if you have a low B12 level, you want to get that thing up. And I mean like you want it in the 500, 600 range. Don't accept when your doc says, oh, you know, normal's up to 200, you're 210. Nah, you don't want that. You want really high B12 levels. Get those B12 levels up. I like them in the 500 to 600 range. Studies have shown that there's a detriment to having just barely normal B12 levels with regard to anemia and neurologic. And again, B12 is important in neurologic control. We know that's an issue in scleroderma, right? So you want those B12 levels up. So keep an eyeball on those and check them I check most of my scleroderma patients with documented bacterial overgrowth. I check them every 6 months. If they don't have trouble with bacterial overgrowth, I check them every year. So here's our problem with bacterial overgrowth. So now here's the normal situation where basically here's well, like rice. Let's take rice for instance. Rice is really easy to absorb, right? So if you eat rice, nothing makes it to your colon. Matter of fact, when I do colonoscopy, I give my patients tons of white rice. rather than just eating Jell-O all day, they can have white rice and white bread, because none of it ever makes it to the colon. It's all highly absorbed. So white rice is not the best for you, but you know, again, it's from the standpoint of absorption, it's wonderful. Here's some beans. So beans aren't well absorbed, and a lot of that makes it to the colon, and you get fermentation and gas from beans. That's kind of well known. Well, what happens if you have bacterial overgrowth? So here's our green area, lots of bacteria. Here's our light green area, light growth of bacteria, and here's sterile gut. Look at this. Now that dark area, lots of bacteria moving way up into the small bowel. So guess what? The rice that would have never seen any bacteria, you're feeding your pets down there. So now they're really happy with you, and they're going to merrily move, sort of metabolize all sorts of fun things like make hydrogen sulfide and methane and metabolize like crazy. So you're going to get diarrhea, and you're going to get gas and bloating and abdominal discomfort. Not just from the beans, which are going to go nuts, but now even stuff like rice, which usually didn't cause you trouble. We have to back this down. And the way you back this down is you got to increase the motility of the gut. You got to basically sterilize this area. That's the sort of the nuclear option with antibiotics. Or maybe you can compete with these guys by putting more friendly bacteria in there. So we use probiotics, pro-motility, and antibiotics. With antibiotics for most scleroderma patients being the major way we treat that disorder. So intestinal dysmotility. So again, motility can become so poor that you can actually get this pseudo obstruction where it looks like an obstruction, but it's not. I'm going to show you what basically normal small bowel, nice and fluffy. You have these little finger-like villi in there, which look really healthy there. I'll show you some guts that don't look so healthy here. So here we have the pseudo obstruction with all these sausage links, sort of dilated small bowel. You should not see that normally. It should just be an opaque area, not these dark areas of gas. And here's that, remember you just saw a little picture of those little friendly little villi? Look here, big bullous sort of cysts and blebs in the wall of the small bowel. This is that pneumatosis. So this is bacteria growing in this area, producing lots of hydrogen, which changes the nitrogen content of these cysts and makes them difficult for the body to expel them. So when I give you pure oxygen, it pulls the nitrogen out of these things by changing the relationship of the two, and they flatten out and go away. So, and then what we do is give you antibiotics to sterilize this area so that it doesn't come back. But again, it looks scary, but it's a pretty easy to treat process. A little on the colon, so constipation in about half of patients. There's not good colonic motility, contraction. Look at this colon, really dilated colon, big, thick, lots of air, really uncomfortable. So it's just not moving, so the air accumulates in there. There's a lot of fermentation going on in your colon. It's actually quite healthy. Without fermentation in your colon and the bacteria producing molecules that the colon lives on. So we see a lot when patients have the fecal stream diverted from the colon, they get a colitis from that because the colon isn't healthy, it isn't getting its nutrition. Your colon gets most of its nutrition from the bacteria, and they're doing nice things to it. So you want those bacteria. You got trillions of them. There's more bacteria in each one of your colons than people who have ever lived on the planet Earth, ever. There's trillions, numbers beyond our comprehension in organisms down there. But for the most part, pretty friendly, and they keep us healthy, and they make things for us that we can't make. But once in a while, they cause trouble when they move north and take up new living arrangements in the small bowel. So again, here's these dilated colons. Once in a while, they get so severely dilated they become ischemic, or they lose their blood flow, and we have to take them out. That is quite rare, so I don't think you'll see that one too often. And then finally, anal rectal dysfunction, usually manifested by outlet problems. The rectum doesn't open properly, or prolapse interferes with defecation, so that can present as urgency, incontinence, fecal impaction, prolapse of the rectum out of the bowel, or out of the bowel and out of the anus. Sense of rectal fullness and incomplete evacuation. So let's get into some diagnostic tests quickly. Endoscopy, one of my favorite things to do. I've been on the receiving end of every single endoscope you can imagine because I've had GI issues. I've had my colonoscopy done. I've had upper endoscopy done. Pretty easy exams these days. Very safe. Give you a nice look at things. Now you cannot see motility. I can't see constipation with this. It doesn't work for constipation. I can't see esophageal motility. I can imply poor stomach emptying if it's full of a vessel or if it's full of fluid, so I can get that out of it. I can sample things. I can look at your esophagus. I can fix a stricture. I can take biopsies and look for evidence of inflammation. In the stomach, we get this thing called GAVE, gastric antral vascular ectasia, which was mentioned. It causes chronic anemia and bleeding. Pretty easy to fix. We have a little sort of Star Wars kind of thing called an argon plasma coagulator, which shoots out an electrically charged gas that, like a paint gun, can paint off the surface and get rid of that for you. So that's pretty easy to treat, actually, with an endoscope. Just for the sake of time, I'll take you a little quick tour. So we're doing an endoscope on a patient here. So there's the pharynx. So we're just getting in. So here we want to stay out of the lungs, so we're going to stay low and go into the esophagus through the upper esophageal sphincter. You can see the vocal cords up there. So here's the entrance to the esophagus. It's closed. Here's the entrance into the lungs. You don't want to go in there. We're going to go down here. So we'll push through. There we go. Here's our esophagus. So a nice, soft, muscular tube. It has more of a pale appearance to it endoscopically because it's skin. It's lined with skin. The same lining as your skin is in the esophagus. It only changes when you get into the stomach, and then we get a different kind of lining, or what we call mucosa. Most of the diseases I see in patients with scleroderma are here, right down in the bottom of the esophagus. This is a normal exam. And you'll see as we get closer here, you're going to see something called the Z line. See the stomach? It looks a little different there. Here's this little jagged line here. That's the connection between the skin-like lining of the esophagus and the more normal bowel-like lining. You can see it quite clearly there. Now we're entering into the stomach. So the stomach's, here we go, gastric body has these nice, what we call rudal folds in here. We should see those in the upper part of the stomach. The stomach kind of flattens out as you get into what's called the antrum. And down here's a little hole called the pyloric channel right there. And when you pop through the pylorus, you end up in the duodenum right here. See these little rings here in the duodenum. So this area is usually pretty well behaved in scleroderma patients. Don't see much trouble there. Basically, this is where all your iron is absorbed, by the way, is right up here in the first part of the So, I'll move on from that. This is motility testing, really important in scleroderma patients. We do a lot of motility testing. It is a very diagnostic finding where you don't see any movement in that bottom part of the esophagus. A little uncomfortable of a test, and we have to do it with the awake, because you have to swallow for us. So the tube usually goes down the nose, but it only takes about 30 minutes. And they're going to have you take swallow after swallow after swallow, and they're going to measure how the esophagus contracts or does not. It is classically abnormal in scleroderma patients. Here's a cool little toy called a Bravo probe. If I want to know why you're not responding to an acid suppressive medication, I might leave this little button behind. And for 4 days, it'll measure the acid in your esophagus, a little gizmo on your belt, and it talks to it by a radio frequency signal. It'll fall off after 4 days and pass in your stool. We don't want it back, it's yours. But while it's in there, it does a nice job, sends all sorts of signals about acid levels, and it has cool little buttons on it. So you push a button when you're coughing, or you push a button when you feel heartburn, or you push a button when you feel chest pain. And then when I get the study back and we download it to the computer, it correlates your button pushes with acid events. And it also gives me an overview of how much acid is bathing your esophagus. So a very nice little toy. Some more GI tract testing. Sometimes we do motilities, we do barium studies or imaging studies. We don't do a lot of good old-fashioned barium studies in the GI tract anymore. Mostly these days really CAT scans, which give us a much more detailed view of the distension or obstruction of the GI tract. On to further testing. This is the breath test. It's called the birthday test. Because we have you come in the office and we give you this special sugar to eat, and then you blow up balloons. That's pretty much a birthday party. So what are you doing, though? Well, we give you a sugar that you can't absorb, but your bacteria can absorb, and then you make hydrogen gas, right? So we give you that sugar, we have you sit around and read a book and blow up these balloons every once in a while, and we put the balloon into a machine, the clinitron, which then measures the hydrogen and methane in your breath. And then depending on how much you get, and when you get it, I can tell whether you have bacterial overgrowth. It's a little tricky because you have to have bacteria that produce a lot of hydrogen, and some of us don't. We check methane because about 15% of you produce a lot of methane, so if we don't get hydrogen, sometimes we pick up methane. So we do it fairly frequently. It has its pitfalls, but in general, a pretty accurate test of bacterial overgrowth. It's super simple to do. You have to hang around for a while, but it's easy. This is endoscopic ultrasounds. It's inside the muscle of the esophagus or the wall of the stomach. We do this. Don't use this test a lot in patients with scleroderma these days. Electrogastrograms are really, there's only a couple in the city. We don't do them. They're hard to interpret. They're mostly a research tool in looking at stomach motility, but never really made it into clinical prime time because they're cumbersome and difficult to interpret. So we haven't done much gastric motility with these. We do this. This is a gastric emptying study. The only study I know that comes with free breakfast. So you come in, we give you some very special scrambled eggs. We have a little radionuclide tracer, and then you eat that. Not too much, no more than a glass of juice. You eat that, and then we can follow it, so we can see how long it takes to empty your stomach. It's a really boring test, because once you eat the scrambled eggs, you've got to hang around for 4 hours, and they occasionally take you back to this big disc-shaped camera, and they scan you. But they can calculate the empty rate. You should be able to empty 90% of your stomach in 4 hours. 80% in 2 hours. If you can't do that, you have gastroparesis. So weak gastro, stomach, paresis, weakness. You're not emptying the stomach well. And then you might respond to pro-kinetic drugs. I like this little guy. We have one of these. They're called a Smart Pill. We were fighting with the insurance companies, as we like to do, to get it approved, but it is an extremely accurate way of measuring gut motility, which is important in patients with scleroderma. I can measure gastric motility, small bowel motility times, and colonic motility times. So I can calculate very precisely whether you have troubles with motility in any of those areas. Again, simple little device. You swallow it, you wear that little box again, push buttons for events, bring it back, and I can actually measure when this capsule entered your stomach, when it entered your small bowel, when it entered your colon, and now calculate transit times. Another test we do occasionally is another capsule you swallow. Notice we're trying to get away from endoscopers, giving you things to swallow full of electronics that send signals to little things you wear on your belt like an iPhone, and it sends back all sorts of cool stuff. So we talked about the pH probe, the Bravo, that sends back acid information. We've talked about this one, which sends back temperature and location information that lets us predict motility. And then this is the Gibbons video capsule, which sends back pictures at a frame rate of 7 per second that show us images of your small bowels that travels through. It downloads into a hard disk on your belt. If you pass, oh, by the way, all these pass in your stool, I never want to see any of them again. And but we don't want your box back. And we take the box and we stick it in the computer, and it either shows us data or images, which is really cool. So we're getting better and better at imaging you guys with these kind of toys rather than our endoscopes, which is kind of nice. And we get physiologic data and images we otherwise couldn't get. So on to treatment, and I'll finish up. So esophagus, lifestyle. Do not eat within 3 hours of going to bed. That is the most important single lifestyle modification you can make if you have reflux disease. If you choose to fill your stomach with bile salts or acid or food, and then you lie down, of course, you're in trouble. You can try sleeping at 30 degrees. I have no financial interest in Medcline, but there's a doctor put together a really cool device for sleeping at 30 degrees. It works very well because it locks you into the 30-degree position. If you try to just put a wedge in your bed, what happens by the end of the night, right, you're all slid down at the bottom of the bed, the wedge is up here, you're scrunched in a fetal position at the bottom of the bed. Medcline, you run your arm through it. It's kind of cool, and by running your arm through this inclined pillow, the arm locks you into place. It also does something very nice. It locks you into a left lateral decubitus position when you're lying on your left side. And when you lie on your left side, the acid has a very difficult time. Gastric contents cannot get in your stomach easily. When you lie on your right side, they dribble right in. So most refluxers have figured out already, I need to sleep on my left side. That's the best position to sleep in. This will not only lock you in on your left side, it will lock you in, it sounds bad, but it will lock you in at a 30-degree angle. So it just came out. We've got one to test, drive. Patients try it out in office. They want to buy it, they do. But I will say of all the wedges and veggies and everything else I've seen, this is the one that seems to work. But again, no matter whether you're using a Medcline or any other 30-degree, by the way, if you want to do 30 degrees without a wedge in your bed, that means taking the head of your bed and putting it on a cinder block sideways. Okay? Now, you may like to sleep that way, but I bet your spouse doesn't want to sleep at 30 degrees the rest of their life. So I would do that. I would get something for yourself. Avoid the usual stuff, mint, coffee, stop smoking, sleep on your left side. Acid suppression. Let me stop for a second and editorialize a bit. I don't know what it is with the lay press and proton pump inhibitors lately, but they're driving me and the American Gastroenterological Association absolutely insane, because they keep publishing studies talking about the doom and gloom of taking a proton pump inhibitor, and it's driving us all crazy. These are, for the most part, association studies, meaning there is no cause and effect. They have not proven that these drugs cause Alzheimer's. They have not proven these drugs cause renal injury. They have not proven that these drugs cause bone density loss. As a matter of fact, just to update you, 8 years ago, CBS, NBC, ABC, all the news channels, you take a proton pump inhibitor, you're going to fracture your hip, your osteoporosis is going to worsen, and I had lots of women stopping their proton pump inhibitors. And I've had 3 patients come to me just this last year with serious complications related to acid reflux because they cold turkey their proton pump inhibitors because they saw something on CBS News and just said, I can't take these anymore. They're going to give me Alzheimer's, going to rot my bones out. I'm done with them. And of course, their reflux came back with a vengeance. I had one develop a very high esophageal stricture. This led to an aspiration pneumonia, which put him on a ventilator in the ICU for a week until I could get the stricture fixed. Why? Because he stopped taking, he was a scleroderma patient, stopped taking his proton pump inhibitor, didn't talk to me, and got into big trouble. Why? Because he heard on the news that these things cause these troubles. Give you a little update on let's talk about bone density for a second. There was a lot of news 8 years ago because it's kind of sexy to scare the daylights out of people with drugs they like to use for their heartburn. It's not so sexy when that gets proven wrong. There are now 4 studies showing that there is absolutely no bone density loss. There is no increased hip fracture risk. It has nothing to do with proton pump inhibitors. Because the cause and effect studies, which aren't as sexy, which take a long time to do, and aren't as much fun to put on the news at night, because they'd rather scare you than console you, didn't get put in the news. The current position of the American Gastroenterological Association is that there is no bone density loss. Gotcha time, okay. So I just want to make that clear, because proton pump inhibitors of the drugs I have are by far the best thing I got for treatment of reflux, which is actually one of the more damaging things with regard to the treatment of this disease. So please discuss this with your physician. I don't want you stopping these things because of these stories. As a matter of fact, I think as time goes by, we're going to find out that there's not a lot of sort of oomph behind them. Really quickly, we do some stuff. We do things to tighten the valve, but we prefer to use PPIs. We go on to go past our laparoscopic repairs here. In stomach, pro-kinetic drugs are somewhat helpful. Metoclopramide, domperidone. You got to go to Canada to get it. It is illegal for me to prescribe it. I go to jail if I prescribe it. Don't ask your doctor for it. He or she will go to jail if he prescribes it. I don't know what the government's got against domperidone. But if you want it, drive to Toronto and buy it up there. But you can't get it here, and we can't write it for you. Just the way it is. Botox into the sphincter, plus minus data there. We haven't had a lot of good data on that one. Intestinal treatments, as I mentioned, low residue, low fiber diet. Antibiotics in a cycling form. So you usually take doxycycline for a week, then the next month it's going to be Xifaxan for a week, then the next month might be metronidazole for a week, then the next month Cipro. Why we change them? So you don't get resistance. But with bacterial overgrowth and Scleroderma patients, it's not a once and done kind of thing. You got to sort of rinse and repeat, if you will, a little bit. Sometimes just cleaning you out with a colonoscopy prep will get rid of bacteria too. But we tend to use antibiotics, and in between, take a probiotic. Probiotics are good. Doesn't matter which one. Align, Culturelle, Probiotica, whatever one they're selling on sale at Whole Foods. But a probiotic with Scleroderma patients is a really great idea. Again, low fiber foods, which I mentioned, FODMAP diet. This is good for gas. If you like gas and bloat from slow transit and Scleroderma, a low FODMAP diet or a modified FODMAP diet is a good idea. I will just give you that website, which I added to this slide the other night because I just heard about it. It's really good at explaining low FODMAP diets and will help reduce your gas and bloat. Oh, sorry. Go back to that one. Yeah. So it's www.myginutrition.com. It sounds sort of general, like it's all about GI nutrition. It really focuses on what's called a FODMAP diet. You can read about it there because we're getting a little slow on time here, late on time here, but it's a diet that helps reduce fermentation in the GI tract and reduce your gas and bloat and belching and such. So you might find that helpful. So I'll leave that there for you. Anorectal treatments are usually antidiarrheal drugs like Imodium and Lomotil. Sometimes tricyclic antidepressants at a low dose can help reduce the urgency of fecal incontinence. And then you can talk to your friendly colorectal surgeon about injectable silicone, sacral nerve stimulators, and rectal prolapse repair. But this is unfortunately not super common in patients. So, GI tract is uniformly affected. The motility of the GI tract is dysfunctional, so we have to end around that with acid reduction meds or try to increase motility with things like metoclopramide. Treatments aimed at controlling symptoms. We don't have a treatment that cures these things yet, but we do have treatments that are effective. Please, if you have Scleroderma, see a gastroenterologist. Right? Sorry, thanks.